Good morning everyone and greetings from Sydney. It's my pleasure to talk on how I perform a high tibial osteotomy. Pre-op planning involves an MRI to confirm the lateral compartment is satisfactory. We obtain an EOS, use the mini-archie technique, correcting to the Fujisawa point, 2 to 2.5 degrees of mechanical valgus, and then we order the appropriate sized allograft tibial wedge which is inserted into the bony defect. The operating room setup has the patient supine. We use tranexamic acid, a lateral thigh support, no footrest. A tourniquet is utilised but only for the arthroscopic component. There are 3 screens in the operating room, image intensifier on the same side, nav and arthroscopy on the opposite side. That's the incision that we use. We put the nav pins in, register the centre of the femoral head, and then perform an arthroscopy and any appropriate debridement, but the predominant reason for the arthroscopy is to register landmarks. The tourniquet is then released and we confirm the alignment and the degree of flexion contracture. In this case, 7.5 degrees of varus, so there's going to be around a 10-degree correction here. The incision on the medial side goes directly through the pes tendons. We leave the MCL intact, but do remove it from the medial aspect to the upper tibia. This is all done without tourniquet, so hemostasis as we occur, and a periosteum elevator is utilised to remove the MCL and allow the osteotomy to open up. The plate is placed directly on the bone. We then pass the guide wire slightly oblique to the axial plane, just proximal to the tibial tubercle, and then a power saw cuts immediately distal to that guide wire. That power saw stays within the boundaries of the anterior and posterior cortices and typically goes 6 to 8 millimetres from the lateral cortex. And that creates a cutting slot which is then utilised to cut the anterior cortex with a saw, protecting the patellar tendon with a right angle retractor, and the posterior cortex is cut with an osteotome at all times, protecting the posterior neurovascular structures of the round-nosed homen, and this is the appearance that you get utilising that osteotome. The osteotomy should then open easily, and if it doesn't, you should check the posterior cortex and make certain it's divided. It's important not to force the osteotomy open if it doesn't open easily, because that results in an intra-articular fracture. And once it's opening easily, put in the stacked osteotomes, as you see there, and then a laminar spreader to achieve the correction that's required, which you confirm. And here you can see we've got this to 2.5 degrees of valgus, which you'd consider satisfactory. And then the allograft is inserted, tapped into position, confirmed with image intensifier, and a plate supplied. With image intensifier. After the surgery, brace in full extension, partial weight bearing, full weight bearing at 6 weeks, radiographs at 6 weeks, and an EOS to confirm alignment at 3 months, and we obtain MRIs at 12 and 24 months. And that's how we perform an osteotomy in Sydney. Thank you.